Hi, everyone. Good afternoon. My name is Gina Mullen. It's nice to meet you all or see you all virtually. We know your schedules are full, so thank you for taking time today to attend our evidentiary CAC meeting discussing coronary intravascular lithotripsy. Our goal today is simple. We want to hear the expertise from our esteemed subject matter experts and examine the evidence together.
Echoing Dr. Mullen, thank you for being here. We're excited for a panel that represents a variety of different practice settings, academic and private practice, as well as a representation geographically from across the country. We do ask that we keep the comments concise and evidence anchored, and when possible, to please reference specific trials, registries, or guidelines. And if you disagree with the expert who's presenting, that's fine. We just ask that you share your rationale and the data that informed your view.
Yep, and a few quick housekeeping notes. The session is recorded. Please avoid sharing any patient identifying information. The raise hand feature is available for SMEs. This is not an open meeting, so only the speakers on the recorded line will be able to speak, as well as the contract medical directors asking questions. When answering a question, please state your name for the record.
And if you've had any changes to your conflicts of interest since your disclosure, please state that before your first comment. We are aiming for about 5 minutes for the initial response so we can cover all of the questions today. We may gently try to keep this on track. We do understand that some questions may take a little more time and others less time, and we do look forward to a thorough discussion, but we want to hear from everyone.
Yes, so how we'll run today, each question has an assigned moderator and suggested SME to kick us off. Other SMEs, and SME stands for subject matter expert, are welcome to add brief reactions or comments. Our objective today is to review and critically evaluate the literature on cardiac intravascular lithotripsy, what it demonstrates, and where uncertainties remain, so we can clearly articulate definitions, patient and lesion selection, technique, outcomes, safety, and how IVL appropriately fits relative to other calcium modification strategies.
And with that, thank you for your time and candor. Let's briefly review today's agenda and participating MACs and move directly to question 1.
All right, so we want to recognize the Medicare administrative contractors joining us today and thank them for moderating and contributing to the discussion. We have National Government Services, CGS administrators, Palmetto GBA, Noridian Healthcare Solutions, Wisconsin Physicians Service Insurance Corporation, Novitas Solutions, First Coast Service Options. And while Novitas and Solutions and First Coast Service Options are represented today, they are unable to read questions during the meeting today. Our esteemed subject matter experts contributing today are Dr. James Blankenship, Professor of Medicine, Director of Cardiac Catheterization Laboratory, and Director of Division of Cardiology at University of New Mexico, Albuquerque, New Mexico, with training in internal medicine, interventional cardiology, cardiovascular diseases, and nuclear cardiology. He had no conflicts of interest to disclose. The next is Dr. Abdul Hafiz. He is a tenured associate professor for internal medicine, director of SIU Advanced Structural Heart Disease Program, associate program director of the Cardiology Fellowship Program at Southern Illinois University School of Medicine in Springfield, Illinois. He has training in internal medicine, cardiology, interventional cardiology, and structural heart disease. Conflict of interest that was disclosed is that Shockwave will fund an unrelated clinical trial in the future, and he was a past RECOR medical consultant. Dr. Corpus is next. He is an interventional cardiologist at Pioneer Heart Institute in Lincoln, Nebraska, with training in internal medicine and interventional cardiology, with no conflicts of interest to disclose. Dr. David Winchester is a tenured professor of medicine at University of Florida College of Medicine and senior medical advisor for Veterans Health Administration, Office of Integrated Veterans Care. He has training in internal medicine, interventional cardiology, cardiovascular diseases, nuclear cardiology, cardiovascular computed tomography, and echocardiography. He had no conflicts to disclose.
Can you hear me now? You are not
yes.
loud. Okay. Dr. Barry Bertolette is an interventional cardiologist, director of the Chest Pain Evaluation Unit, and staff cardiologist at North Mississippi Medical Center in Toluca, Mississippi, trained in internal medicine, interventional cardiology, cardiovascular disease, endovascular and vascular medicine, congestive heart failure, and transplant change, and is on the speaker bureau in the past fishing wave. And are you getting an echo?
A little bit, yeah.
Okay, why don't we go back to you and I'll try to fix my audio.
Okay, no problem. So I think you just read Dr. Bertollet. Dr. Edward Toohey is an attending physician at Bridgeport Hospital in Bridgeport, Connecticut, Milford Hospital in Milford, Connecticut, and Danbury Hospital in Danbury, Connecticut. He has training in internal medicine, interventional cardiology, and endovascular intervention, cardiovascular diseases, nuclear cardiology, as well as adult comprehensive echocardiography. I'm so sorry. No conflicts of interest to disclose. Dr. Tanvir Robb is a professor of medicine of interventional cardiology in the Division of Cardiology and eminent physician for Department of Medicine at Emory University School of Medicine. He's also the section chief of cardiology and director of interventional cardiology and cardiac catheterization laboratory at Emory Decatur Hospital, as well as a master interventionalist for the Society of Cardiovascular Angiography and Interventions. His training includes internal medicine, interventional cardiology, cardiovascular diseases, and he is a registered physician in vascular interpretation for the American Registry for Diagnostic Medical Sonography. He has no conflicts of interest to disclose. So we will start with question number 1 and turn the floor over to Dr. Moynihan.
Hi, everybody. Eileen Moynihan for Noridian Healthcare Solutions. This question is for Dr. Bertollet. Does the evidence demonstrate that intravascular lithotripsy is effective for the treatment of severely calcified coronary vessels? And is there evidence for use in moderately severe calcified coronary vessels?
Yes, thank you for the opportunity to address today. So the short answer is yes, there is nice evidence. This has been demonstrated in a series of trials called the Disrupt trials. The first Disrupt 1 trial was a smaller trial looking at 60 patients in the United States and Europe that was treated with IVL. There was a device success rate of 95.5% with a very low risk of any kind of complication. So freedom from any kind of complication was 95%. And in this initial trial, it showed that the mechanism of action was actually fracturing of the calcified plaque as the primary mechanism of action. In the Disrupt 2, this was a post-market study that was done, real-world population in the United States and Europe. This was 120 patients, so 94% of these patients were judged to have severe calcification, meaning that 6 had moderate calcification. And then IVL delivery success for a treatment was 100% here, with reduction of the stenosis that was being treated down to 8% after the IVL, and again, a very high freedom from any kind of complication. Disrupt 3 was the pivotal trial in the United States, and this was 431 patients. This was performed in the United States and in Europe. And with this, again, there was a high success rate at 92.4% in delivering the device. When we looked at OCT imaging in a large number of these patients, we saw that fractures were demonstrated in 67%. So again, softening up this calcified plaque. And importantly, when we looked at these patients, looking at the ability to expand the stent completely, which I believe is a good mark of success, that the stent expansion was 101% of the stent size. So pretty phenomenal there. And again, we see that there was a low complication rate. And then finally, when we go outside the United States, there was the Disrupt CAD-4 study that was done primarily in Japan. And then this showed very favorable results as compared to what we got from Europeans in the United States in the CAD 1, 2, and 3 studies. These results are summarized in Table 3 of Reference 4 in your packet, and it shows very good consistency amongst the different clinical trials, looking at an experimental and real-world population, and looking at different populations of people, whether they be from Europe, from North America, or from they be in Asia. Now, and this is my own opinion, I looked at the Orbit 2 study, and the study design for the CAD-3 was quite similar to Orbit. And in this, when we look at it, we see that there were similar outcomes with perhaps less non-Q-wave MIs or, enzymatic kind of issues that we see. Now, one of the nice things that we did learn from the Disrupt CAD-3 study is that there was a run-in population that was looked at. And when we looked at this, we found that the patients that did their first several procedures basically did not have a learning curve. And so their outcomes at procedure 1, 2, and 3 was the same as it was at 11, 12, and 13. And that's important because it tells us that this technology is intuitive. And then when we looked at the CAD-3 post-market approval study, we actually found that when we opened this up to a real-world population, that we got better, if not equal results in a somewhat safer population in a sicker population. And I say sicker because there looks like that the calcium in the lesions were a bit more complex, as well as the lesions were a bit more stenotic. And then finally, there is a nice reference from Dr. Musa, who looked at IVL versus rotablator, and so another technology to treat calcified arteries. And he found that there were trends toward maybe better outcomes, lower complication rates, but what was significant is that there was shorter fluoroscopy time. And so that means that there was less time spent in the cath lab in order to achieve a good outcome from this. And so in a summary from the severe, we do see that there was exceptional procedural success, anywhere from 90 to 100%, very favorable stent profile with a very low risk of perforation, which is contrary to what we may do with atherectomy. And there seems to be durable results. We have followed in the CAD-3 patients out now beyond 2 years with durable results. And then the final question for that is that what about in moderately severe calcification? And that has been looked at specifically in a reference that we will add later. This was first author Askoy, A-S-K-O-Y. This was in Circulation Cardiovascular Interventions, Volume 12, Issue 11 in November of 2011. And he looked at a population of patients that had both moderate and severe calcification treated with IVL. And what he found here is that that IVL was very feasible. It was safe in treating these patients that had both moderate and severe calcification. So it was a useful tool in that population of patients as well. And so while there's not as much data with the moderately calcified, there is some that is in the literature that would support its use in moderately calcified vessels. I will be happy to answer questions. Thank you.
Thank you so much. Are there any responses to that? I'm sorry, Eileen, I was trying to do a 1 minute warning and then it was like playing double dutch. So I'll be a little better next time. But yes, if any speakers want to comment on that, I'll go on mute. Thank you.
I think Dr. Bertolet was very complete. Thank you. Should we move on, hearing no other comments?
Yes.
Dr. Tui, how do we classify the severity of the plaque that is moderate or severe in an objective way? For example, we've seen calcium angles, plaque without motion. What definition should be used, and does it make a difference in the outcomes?
Yes, hi. Thank you for allowing me to participate in the forum today, and I appreciate the question. I'll try to be brief. Typically, we look at calcification where a moderate level is developed by an angle or an arc of calcium within the vessel of less than 270 degrees and a length of less than 5 millimeters, an absence of nodular calcification, and not an extensive amount of circumferential involvement. And severe calcification would be a progression of that, where the arc is greater than 270 degrees, often 360 degrees circumferential calcium, and a length greater than 5 millimeters, so extensive areas of restrictive calcification. Presence of calcified nodules, which is another separate indicator where it's not circumferential in terms of the arc, but a large nodule compressing the artery and reducing your ability to expand stents is present. And smaller vessel diameters as well, certainly vessels that are less than 3.5 millimeters. And we've focused the literature in terms of those types of lesions because the calcium arc in there, if the calcium arc is greater than 270 and there's 360-degree calcification, nodular calcification, or small vessels, those are vessels that are at high risk of stent underexpansion. And in all of the studies, and Dr. Bertolet did a great job of going over all of that disrupt data, but that's been the corollary to inappropriate or stent expansion and negative outcomes. So those are the definitions that I believe are relatively uniform throughout the literature, with the moderate degrees of calcification being able to be treated with non-compliant balloons or a cutting balloon, with more moderate to severe calcification requiring treatment with either lithotripsy or rotational atherectomy. Thank you.
Do any of the other speakers have any additional comments?
Hi, this is Stan here. Thank you, Dr. Tui. I did add 2 references for you all because what Dr. Tui described was described by Fujino in Neurointervention 2018, where they stated a OCT-based calcium scoring system, and also an article by Schlafmitz in Circ Interventions from 2020 regarding intravascular image-guided PCI and a universal approach for optimization stent implantation. Both these articles are important in supporting the question number 2. So I think, Dr. Mullen, I think I already gave you those references to it.
Thank you, Dr. Rob.
Thank you, Dr. Rob.
Anyone else?
Hey, Dr. Professor, you hear me? Hello?
Yeah, we hear you.
I'm sorry. So I just want to add that, you guys nicely kind of describe the calcium here, but most of these descriptions are based on intravascular imaging, OCT and IVUS. And I think in most labs, typically don't do that on a routine basis, especially, outside trial settings. So the definition of severe calcification, pure angiographic imaging is typically it's a calcium that's encompassed both sides of the vessel wall, and you can see that without cardiac motion. So that's typically, in the literature is also classified as severe calcium. Moderate is typically calcium that you can see with cardiac motion. So just an add-on, if you don't have intravascular imaging techniques, those are definitions just, based on fluoroscopy.
So would they all come out to be similar measurements? Because if you have a bunch of studies and this is all measured in a different way, does that all mean the same thing to you?
Let me answer that, because I think per guidelines, they're encouraging class 1 recommendations for these complex procedures, which for the most part should not be done in a bread and butter hospital. Remember, calcification can be on the surface of the artery and still be severe, or within the artery. But I think if we're going to do a procedure for stent optimization, you do need imaging. And I think the current definition of standard of care will be based on IVUS or OCT imaging to define what has already been described by Dr. Tui. So I think, a lot of people have calcium on their coronaries. If you look at it, chest X-ray by fluoroscopy, that alone does not measure to the depth of what we want to do with complex PCI using any kind of atherectomy, and particularly IVL.
Thank you so much, Dr. Rao. This is Denise Nachowski from WPS. So therefore, what would you prefer as, do you think is more of the gold standard that we should be using? There's multiple articles that might be using IVUS, some use OCT, and then some others have suggested non-imaging. So as we are trying to find what is the best for us, what might be guidelines that you suggest?
Do you want to answer that, or do you want me to answer that for you?
I mean, I think I could field it. I think the availability of high-definition IVUS and OCT is relatively prevalent throughout more of the labs that are doing higher-risk cases and using this technology. And I think we have high-definition IVUS in our lab. We don't have OCT. Yale, the mothership, has OCT available, but they don't use it all the time for this. If you look at all of the literature that was attached to the packet, there's a variance in whether you're using IVL and OCT, and both of them are using artificial intelligence enhanced analyses. And I think it should just be standard that intracardiac imaging is used, whatever technology that you have, in association with these procedures, because I think it correlates with better outcomes, and it definitely correlates with more appropriate use of the devices.
Thank you so much for that. The buzzword of the intracardiac imaging is very helpful, I think, for us.
Of course. Thank you.
And Dr. Moynihan, can you see that Dr. Bertollet and Dr. Rob have their hands up? I'm going to defer to you. I didn't know if you could see their hands up.
No, I can't see them.
You
Sorry.
can't? Okay, no problem. I'm happy to let you know, but Dr. Bertollet is off mute if he wants to go, and then next, Dr. Rob.
Yeah, thank you very much. I don't disagree with my colleagues and what they've said there. I think we do want to be careful at mandating that IVL need to be used prior to IVL, because it may be that if we are using ultrasound or we're using OCT, is that may not be necessary to determine it's a severely calcified vessel in every case. And I'd hate to see that we mandate that as a precursor procedures. I do think it's useful in the optimization of the post-procedure, but just that definition of calcification, I would lean toward what Dr. Corpus said earlier.
So what I would like to say is that, for 20 years we have stayed behind what intravascular imaging adds, but the good news is that from 20% utility, we've gone up to close to 65 or 70% in this country, particularly as we deal with more complicated cases. So IV imaging has increased, and there are algorithms like MLD Max for OCT and a similar algorithm for IVUS that helps guide your therapy. So I think we need to look forward that imaging is here to stay and is going to continue on, because the guidelines have given us class 1 indication both here and in Europe. And I think that will be the path we'll take in defining all this in therapy.
I agree with that. And then there's Dr. Corpus. However, if you're looking at the safety of the procedure and the future of maybe moving this into a ASC setting, I think a lot of those centers will not have imaging, intravascular imaging. So I think I would also be cautious and careful to tie this definition only to intravascular imaging. So I think, as IVL will hopefully penetrate, with safety into everyday practice, I think it's unrealistic to really say that you don't have the IVIS and OCT every lesion. And then the definition from fluoroscopy in the private practice clinical setting, outpatient setting still could be valid.
Hey, Gina, do you see anybody else?
I don't. Thank you.
All right. I think we can move on at this point. Thank you, everyone, for your responses. This one is for Dr. Blankenship. What's the best success measurement for this procedure, as it does not seem to be measured consistently in the literature? We see flow, pressure across the width of the stent, residual diameter, stenosis less than 50% or less than 30% or less than 20%. Can you comment?
Well, thanks for the question. It's an interesting question. Generally, in interventional cardiology, criteria for a successful procedure are lack of complications during the procedure, and by that I mean things like perforation and severe dissection, and a final residual stenosis, which is less than, and then you fill in the blank with a percent. So it's fairly easy to define when you see a perforation, when you see a severe dissection. The question here seems to get to the question of physiology. In other words, do you need a measure such as a fractional flow reserve to judge success? And I think the answer to that is clearly no. In terms of flow, we generally would say that normal flow, which would be in the language TIMI grade 3 flow, would be prerequisite, although acknowledging that in some cases you get slow flow or no flow, but in general, TIMI class 3 would be a prerequisite. And then probably the key question here is what would be the acceptable residual diameter. I think usually with stents less than 10% residual in-stent compared to the adjacent normal arterial wall would be criteria for kind of normal stenting. I think given the fact that we are dealing with a particular situation of severe calcification, it's more appropriate to loosen that up a little bit. So I think 20 to 30% would be an appropriate criterion.
I lost my microphone there for a second. Thank you. Does anyone have anything to add? All right, then I think I will turn it over to the next CMD.
Good afternoon, everybody. I'm Jennifer Abrams. I am one of the CMDs from Palmetto GBA. Thank you for being here today. My first question will be to Dr. Winchester, and it is a subject that we have already started to touch upon, but perhaps you can expand a little bit more on what the best methods are to evaluate a lesion prior to needing IVL. For example, FFR, CT, invasive, optical coherence tomography, the OCT, or intravascular ultrasound. These are all measured by different techniques in the different articles that we've seen. And does the different techniques utilized, do they make a difference in the results that we're seeing?
Thanks very much. This is David Winchester. I'm just going to summarize a couple of the definitions that were used in the studies. In the Disrupt CAD studies, the methods described lesions that needed to be severely, quote, severely calcified de novo lesions of less than 32 to 40 millimeters in length and with at least 50 to 70% stenosis. Looking deeper into the supplemental materials for those studies, it was further defined as, quote, Evidence of calcification at the lesion site by A, angiography with fluoroscopic radio opacity is noted without cardiac motion prior to contrast injection, involving both sides of the arterial wall, and in at least one location and total length of calcium of at least 15 millimeters extending partially into the target lesion. Or by B, IVUS or OCT with presence of greater than 270 degrees of calcium on at least one cross-section. Then from the Benelux IVL registry, we have the following definition. Intravascular ultrasound score, 360-degree calcification, calcium extending over 270 degrees, measuring at least 5 millimeters in length, detection of a calcified nodule or a vessel diameter less than 3.5 millimeters, or OCT score, 2 points for a maximum angle greater than 180, 1 point for a maximum thickness greater than 0.5, 1 point for a length greater than 5 millimeters. If intravascular imaging was not available, severity of calcification was assessed angiographically. Radiopaque density is visible without cardiac motion before contrast injection affecting both sides of the coronary artery wall were considered a hallmark of severe calcification. So in summary and in my assessment, while the trials did use several techniques, I think that they had fairly consistent definitions between them. I think more importantly, as it relates to outcomes, I could not find where the trials broke out the results based on the different techniques that were applied. And in my opinion, I do not think that the different techniques would make much difference in terms of patient outcomes.
Thank you very much. Are there any follow-up questions or comments before we move on?
Can you hear me?
Yes, ma'am.
Okay, this is Dr. Lovelace. If angiography underestimates the calcium in the coronary arteries, from what I understand, up to 40% of the time, is there anything that should be IV ultrasound or OCT be done to help with patient selection and understanding which patient help predict which patients may have successful stent expansions before the procedure?
Yeah, I think you bring up an important question, although the problem, I think, at least in terms of the data as it was reported, is I didn't see where they broke out the difference between angiographically based severe calcification versus some of the invasive imaging options. I do see that a couple of our other experts, at the outset, it was suggested I had interventional training, and I don't. So let me go ahead and pause here and defer to some of my other colleagues on the call who do have experience in the cath lab.
Dr. Blankenship, and then Dr. Burton-Lay.
Well, I think one point that is brought out by the question here, there's really two questions. One, is it appropriate to undertake an intervention on a procedure? And then the second question is how to do it. And I think the suggestion that fractional flow reserve by CT or invasive techniques, that really gets to the question of should a procedure of any sort be done? And then the second question is, if you're going to do it, how do you decide what tools to use? And that's where the optical coherence tomography and the intravascular ultrasound come into play. And they're useful in helping to determine whether, what technique you use. And then a final criterion that I think hasn't been brought up yet is that if you guess wrong and you think that you don't need intravascular lithotripsy and you inflate a balloon and you can't get the lesion dilated with the balloon, in other words, you blow up the balloon and there's still a big dent in it where the calcium is, then that's an indication that you might need the intravascular lithotripsy.
Yeah, I was just going to echo the exact same point that Dr. Blankenship just concluded with, is that if we do choose an alternative path, such as balloon angioplasty to begin with, and we see that there is initial failure, that we always can go back to doing the IVL therapy. So it's not like you have to pick up front. You could start with a balloon. If you get failure there, you could go to IVL.
And can I just add, too, that as I'm sure that Dr. Burton-Lay knows better than I, that, again, if you guess wrong and put a stent in and you can't fully dilate the stent, then even then you can deploy IVL, and that's been proven to be a very effective remediation when you can't get full stent expansion.
Dr. Rab?
Yeah, so the specific question, let me just say that about CT as a measure of evaluation. That has not been studied at trials. Trials are ongoing. It will be the future. A lot of stuff added reference. It just published in JSky by the group from Minneapolis. It will be part of the 4F study that Sandoval et al. Published it in JSky just this year. But it's not the standard yet because it's still part of trials. And I think if you want any measurement per se, it's still probably the gold standard still be imaging and with OCT or IVUS. The CT has not yet taken off, but probably will be the wave of the future because more CT angiograms will be done and people will need CT-guided PCI.
Thank you very much, everyone. I appreciate it. If there are no other comments, I'll move on to my next question. My next question is going to be directed toward Dr. Hafiz. The evidence does not necessarily compare the same artery to the same artery. Are there any standards on which the arteries are appropriate for treatment based upon current evidence?
That's muted. Can you guys hear me?
Yes, sir.
Thank you for the question. So I'll break this down, but the short answer is probably no. But here's an explanation. So at the risk of sounding very, very simplistic and probably more common geared towards the non-cardiologists in the meeting, there are 4 main blood vessels in the heart. The left main on the left that branches 2 vessels, the LAD and the circumflex, and on the right side, the right coronary artery. So to rephrase the question, if there is any individual artery-to-artery outcome measures, the answer that I found was no, not necessarily. Are there any studies explaining if there are per protocol selected use of IVL in a particular vessel and how that affects the outcomes? Again, the answer is probably no. Do any studies break down the use of IVL in different vessels? Yes. Well, most studies do report the percentage of the different use frequencies in different vessels. And in terms of the frequency, the LAD was the most common vessel and the left main was the least common vessel. And the right coronary artery and the circumflex, depending on the study, they can go back and forth. Another way to answer this question is, are there any characteristics chosen to target the vessels? And the other speakers have spoken in great detail. Yes, they are, and some of my comments will be overlapping theirs. So the size of the vessel, the length of the coronary artery calcification, the length of the target lesion, the degree of the calcification, these are all characteristics which will define success in a particular vessel, and not particularly the vessel itself. So the first one will be the size of the vessel. So by definition, the technology uses a balloon sizing of 1:1, unlike the other atherectomy devices, which are downsized. So you have to pick an IVL catheter, which is appropriately sized, and technology comes in 2.5 to 4 millimeter vessel. So the target lesion in the vessel has to be in that range to be treated for the reference vessel diameter. And the lesion severity, as indicated by others, has to be at least 50% or more than 70%, depending on which trial you look at. The length of the target lesion was chosen in the most prospective studies, including disrupt studies, but many retrospective studies left it to the operator, essentially. There's a lot of heterogeneity in what studies defined afterwards. The longer the lesion calcific zone, the less compliant we know the vessel will be and making delivery difficult. Therefore, when it was chosen what lesions to go after, there were different cutoffs that were chosen. For example, they varied from 10 millimeter to 15 millimeter, and a maximum of 32 millimeter to 40 millimeter. And the references are in my reference that were emailed, depending on the study. So there were several follow-up real-world studies that looked at this, and the criteria were not strictly met. Of note, to determine both the above criteria, intravascular imaging was done initially mostly with OCT, and later operators did not use OCT, and they used mostly IVUS. In the follow-up studies, what we observed in the real world, and many labs don't have OCT. For example, even our lab does not have OCT, but we do use heavily intravascular ultrasound imaging. Each also OCT one can add more contrast, and there are scenarios where you cannot use it. Moving on to calcification. Calcification is, as the others have defined, there's very specific criteria for calcium. You define severity, there's length, there is the arc of angle of calcium, there's the depth of the calcium, and all those have been already, so I'll skip because they've been defined. So in conclusion, IVL is performed and can be performed in any epicardial coronary artery with a baseline TIMI 3 flow, although it has been used in the CTO instances. IVL can be safely delivered to target lesion in a vessel that fits the device 1-to-1 sizing fashion, regardless of the proximal, mid, or the distal location. In a full analysis of District 1 to 4 trials, it was highly effective in achieving residual stenosis less than 30% in 92.4% patients with in-hospital MACE of only 6.5%, which is pretty remarkable. And this MACE was mostly driven by non-Q-wave myocardial infarction versus death or STEMI. The target lesion failure was also less than 10% at 30 days, specifically 7.2%, and less than 1% stent thrombosis, which is also very remarkable. Studies have shown varying outcomes based on the baseline profile of the patient, such as the outcomes are generally worse if you use it in acute coronary syndrome versus stable angina, or if you use it in bifurcation situations, or if you use it as a bailout. But again, I'm not aware of individual artery-to-artery comparison. All 4 vessels have been targeted. All distal, proximal, or mid locations have been targeted. I have given references 1 to 4 in my response via email.
Thank you very much. Does anyone else have anything to add or any follow-up questions?
Dr. Corpus, the only thing I would add, that was a beautiful presentation, but, the IVL catheter balloon that comes different sizes, it's 2.5 and higher, and, 4 is the highest number. So vessels of less than 2.5, currently cannot be treated with IVL.
Thank you. Anyone else? Then I will move on to the next question, which is being directed to Dr. Corpus. Are there standards set on the techniques for current standard of care procedures, such as rotational or laser atherectomy, cutting balloons, high-pressure balloons, etc., and do those standards affect the outcomes of these procedures?
Sure, thank you for the opportunity. I don't have the video since my Wi-Fi is not that great, so I'm just the microphone. So I would start with the traditional balloons, high pressure balloons, so-called non-compliant balloons. We use them every day. Obviously, regular balloons have a burst pressure of lower atmospheres. These balloons, high compliance balloons, can be up to 20 atmospheres before they burst. As a matter of fact, there are higher balloons that go up to 40. Typically, we use this as first-line treatments, to try to dilate harder lesions, such as calcified lesions. Techniques are pretty much similar to regular balloon procedure delivering inflation. Most of us would actually move on to something else if you see the balloon is not completely deployed. Cutting balloons and scoring balloons have come to the forefront a few years ago. They are hard to deliver. Sometimes calcified lesions could be, treated with that, with some initial data showing that there's better luminal cross-sectional area. However, the shortcomings of these balloons are mostly the ability to deliver them to a calcified lesion, even with body-wide techniques or other techniques that are hard. So if you look at the outcomes of these balloons and compared regular balloons, there have been no difference in several studies. So I think, these are first-line treatments, but overall did not add significant amount of ease and positive outcomes to the procedures. Rotational atherectomy of the bladder has been approved since 1996. I would just go for the approval indication, which was in lesions that can be crossed with a guide wire and calcified. We have been using this with good success. Most of us would go to a rotablation if the balloon cannot cross the lesions. This is the primary indication nowadays for rotablator. They come in different sizes, 1.25 to up to 2. And as far as the question with regards to complications, there has been little correlation between size and operating experience with regards to complication. The bigger the burst size, the higher complication rates, such as perforation, and the operating experience obviously is also a significant factor here. Fewer cases, more complications, as with many other cardiac procedures, more cases, less complications. So I would say as a standard, rotablator would be used if the wire can cross the lesion, but the balloon cannot cross the lesion, or there's severe heavy calcification we'll talk about later in this presentation, the concomitant use of rotablator and IVL. Moving on to laser atherectomy, this has been approved, for broader indication, typically in lesions that cannot be crossed. So this is actually a modality that can be used for lesions that cannot be crossed, also in acute myocardial infarction situation, and also underexpanded and in-stent restenotic lesions, and also vein grafts that's approved. The use of laser cannot be used less than 2.5 vessels as well, so there's a limitation there as well. I think I would speak for the community of cardiology and interventional cardiology that the laser procedures are not as common as they initially we thought they would be. So I would say that typically a laser is reserved to situation where there's a coronary occlusion or a stent problem, in-stent restenosis or expanded stent, under-expanded stent. Since this laser does exert a significant amount of pressure, that will facilitate the stent expansion. And just the last one, quick comment on orbital atherectomy, which, it typically was the same indication as IVL, a rotablator initially in the studies. However, if you look at the data, there's a higher rate of perforations, complications than rotablator. So this typically is not as favorably looked at as rotablation. And if you look at the real-world data with concomitant use of IVL and orbital atherectomy, typically rotablator would be the choice with concomitant use.
Thank you very much. Dr. Blankenship, you have something to add?
That was quite a comprehensive answer, and thank you for that. Trying to look at what the intent of the question is, maybe the question is, are there standards that should be set for the technique of intracoronary lithotripsy? And when I try to think of, are there any standards that should be set for its use, I think it's probably nothing more than just noting that the recommended inflation pressure is 4 atmospheres and probably should not exceed that. I don't think there's any reason to under usual practices. And then, of course, you want to get the device across the lesion. But I can't think of any other standards that I would want to set. I mean, there are certainly standards for other devices that are very important for their safe use, but I can't think of anything else for lithotripsy. Thank you.
Thank you. Dr. Raab?
So, little tangent to this. If this is about IVL, let me just let you know there are 4 of the devices being investigated in the market as they get better and better because the safety profile of IVL compared to other mechanical atherectomy devices such as rotablator or orbital atherectomy. In terms of shock wave, they have a device which does not have a balloon on it, known as Javelin, which appears to cross lesions a little better than the current balloons. This does not have a balloon on it. It will just have a vibratory core at the end to create a passage similar to what rotablator is. Currently, clinical trials here has had some approval in Europe. So the technology continues to evolve because there's safety in this device.
Comments.
Yeah, thanks for the comments. I thought the question was, other modalities except for IVL. That's why I didn't address the IVL. It looks like, it was actually the current standard, which, was other atherectomy devices.
That's correct. Thank you.
I just want to add a comment about the inflation pressure. According to IFU that I'm aware, after 4 atmospheres, they do want you to go to 6 atmospheres and then come down, and no greater than 6 atmospheres, just the addendum 12 is already said.
Dr. Hafiz, did you have anything to say?
I don't know if you guys.
He just said it. Just as a housekeeping reminder, if you could just state your name before you speak, just so we have record of it. But thank you so much, Dr. Hafiz.
Just a quick comment of just if you look at the current recommendation from the company, the studies did show that 6 atmosphere inflation, that's what the standard. Right now, they do not recommend necessarily that, that post-inflation. So just go to 4 and then do the pulses and come down.
Thank you, Dr. Corpus. If not, then I will pass the banner on to Dr. Nachowski, who will be taking over.
Thank you so much. I'm Denise Nachowski, and I'm one of the CMDs at WPS. From the start, I just really would like to echo what my colleagues have said here, that thank you so very much for your time that you're taking from your busy schedules to provide your expert insight to this procedure, its safety, and its clinical utility compared to the current cardiac calcium debulking interventions. So my first question goes to Dr. Rob. Can you please define, and I know we're kind of getting the flavor of what we should be doing, but can you please define A, the patient population, and B, the angiographic criteria for which lithotripsy would be the preferred procedure or alternative to the current procedures that we have available, such as rotational or laser atherectomy, the cutting balloons, the high-pressure balloons, etc., for these heavily calcified lesions. And when you explain that to us, could you please define it in context to these 2 points that are of concern to me? The shockwave coronary lithotripsy system, which got approval, the PMA approval, was based on the Disrupt CAD 3 trial. Okay, and the approval of this device and the procedure is indicated for lithotripsy-enabled low-pressure balloon dilatation, severely calcified, and a de novo lesion prior to stenting. That is what is required. The PMA also has very detailed inclusion and exclusion criteria, such as the lesion site. It cannot be an osteal lesion. You cannot have left main. It cannot be a total occluded lesion. The target vessel diameter cannot be, it has to be within 2.5 to 4.0 millimeters or centimeters. I'm sorry. The length is not to exceed 40 millimeters, and other criteria about the patient, such as the patient can't have class 3 or 4 heart failure, cannot be on dialysis, a creatinine level cannot be elevated beyond 2.5, the EF has to be greater than 25% on these patients. So with these very strict criteria, my concern in reading these articles is that the approval suggests that it's allowed on a much more low-risk patient population and a low-risk procedure compared to the other calcium debulking procedures that we have right now that are currently available. And my second concern that I have is in regards to the FDA supplemental approval for this device in 2022 said that they're going to increase the maximum pulse count from 180 to 120 when using lithotripsy. What literature or data supported in this supplemental version the need to increase from 80 to 120 bursts? Has this changed the outcome? Has this changed the safety profile in regards to this procedure? So thank you.
Thank you very much. The very broad-based question. I think what we need to look at is this going to be regarding IVL. It should be not just focused to what you want to do today, but looking forward, because IVL is here to stay. Now, all these criteria that were issued by the company when it first came out and released to the market, of course, everybody wanted to be safe with it. But I think if you look at let's answer each one at a time. So, a patient population, I think all comers. I don't think low ejection fractions necessarily preclude lithotripsy, because in terms of safety, the debris generated by rotational atherectomy or balloon atherectomy can actually stun the ventricle to the point that it decompensates the patient. Whereas, lithotripsy is just a balloon. It just does not cause the dismemorization or disruption of flow dismemorization like the other devices do. So it's safer. In terms of calcified coronary lesions, yes, it is there for calcified coronary lesions, but I think most of us would not use any of the other devices, including lithotripsy, if they did not have a full arc of calcium, or at least an arc of calcium based on imaging, which is more than 180 degrees. So that is some of the criteria that should be used. And the third thing that's not mentioned is most of us would do a balloon test, that if a lesion did not yield to high-pressure balloon inflation, particularly with a non-compliant balloon, then if there is indication of some kind of plaque modification, either by an atherectomy procedure or lithotripsy. Now, a lot of these things were based, the indications based on clinical trials, particularly Disrupt trials and the trials out of Japan. But I think we have broadened that. This is device safety. I think, and these are coming off registries and other data, not necessarily trials. We have broadened the use because the device is safe. It does not cause perforations. It can be used in patients with low ejection fractions, does not cause dysregulation. In many instances, it is first-line therapy of plaque modification now. And very commonly, it is used also after rotational atherectomy that, as I indicated before, the newer generation devices that are being developed, including one from Shock where they don't have a balloon on it, will allow passage of a device which is previously thought to be balloon uncrossable. Okay, so the ideal devices are coming to balloon uncrossable lesions, and they are being developed and currently are in trial. Now, in terms of use in left main osteostenosis, including osteocyte branch, they're no longer exclusions because it's being used in registries right now all over the world to be used in that kind of setting, and it's safe. Now, the 120 pulse count, again, is safe. Otherwise, the FDA would not have approved it. It's safe. It's used now for the, previously we had a limited pulse count up to 60. Now it's 120 because there are resistant lesions that actually, even after rotational atherectomy or orbital atherectomy or after high-pressure balloon, do not heal. And particularly in the in-stent restenosis, where there's a calcified plaque outside the stent boundaries, which is not getting modified, 120 pulse is quite reasonable to use to get that benefit. So it is safe. So I think that in terms of going back to your questions, patient population, all comers, no longer low ejection fraction, and I think it is a reasonable alternative, and I think as devices get modified, it might be first-line therapy, bringing devices that will be crossable and those defined as balloon uncrossable lesions. Thank you.
I think, Dr. Bertolli, you may have an additional comment.
Yes, I wanted to address the comment about the exclusion criteria. And this was actually preset because when they designed Disrupt CAD3, it was designed after Orbit 2. So it had to mirror, and the FDA sort of enforced this, it had to mirror the inclusion-exclusion criteria of Orbit 2. And so the criteria here that were exclusion criteria in that Disrupt 3 were not because of the catheter would not, or this device wouldn't work there. It was because this was an FDA mandate. And in fact, in many of these circumstances, this is the utility of the device. And so, and in fact, my very first patient that I did was a patient that was on dialysis, that had frequent admissions into hospital and had heavily calcified coronary disease. It was turned down for bypass surgery, not a candidate for other procedures, atherectomy procedures, because of a low ejection fraction, and had to require Impella support to do that. So again, this is the beauty of this catheter, is that we're able to help people that present technology doesn't allow it. So these exclusion criteria were only for this study and a scientific study because of previous studies and are not directed at the catheter per se.
Thank you so much. My follow-up to this, though, is, now I forgot my follow-up to this. You guys were just too interesting. The question that I have, though, kind of as a follow-up, though, is where is it, do you have data or literature? I would just like to know, I mean, one of the results was, as I said, is it went from 80 to 120, and it's fine. It wouldn't have been otherwise allowed to go up to 120 if it wasn't safe. But why did we need to do that? Is there study, do you have literature that says now using the 120 that the safety profile is okay, that there's not worse outcomes? And if you have any literature to send to us so that we can use it as a reference when we are writing policy.
I think that most of these came from resistant lesions that are not, particularly for in-stent restenosis, for example, that they are not yielding to traditional therapies, including atherectomy devices or high-pressure balloon. And it is felt that if we had more pulses, we probably could get that effect. Rarely in de novo lesions do you have that kind of situation. But certainly very hard resistant lesion, at least for in-stent restenosis, it's felt that more pulses would give you the benefit, because then you would have to switch out the device to maybe a laser even to take out the plaque behind the stent, for example. It just was felt that we kept this even longer and gave more pulses, we could have a better benefit than what the laser. So in terms of trials, there really no trials per se, but I think there's a lot of literature and anecdotal results and registries to suggest that there's a benefit. Okay.
I would also add, I agree with all that. I would add that this balloon length is only 12 millimeters. There's lesions that we're treating that are longer than 12 millimeters. So I think the ability to give you more pulses, more impulses per lesion, it will actually enable you to treat longer lesions and more calcified lesions. So I would say that probably as a post-market cases were coming in, since we established safety of this procedure, I think, by going up by 40 more impulses, I think we're able to treat the more calcified, the nodular lesions and the longer lesions.
Thank you for pointing that out. I was going to say that you could use that, if it's a longer lesion, you have to change out and put a fresh device in, which is very costly. And adding these pulses gives you an opportunity to do more areas rather than one focused area in longer lesions.
I think this has been a great discussion, but I'm going to encourage us to wrap it up to move to the next question so we can continue on since we still have so many questions.
Thank you. And for the two that still had their hand up, I think Dr. Blankenship as well as Dr. I'm not sure who the other one was. If you just want to write in or give us your resources, it'd be greatly appreciated. My next question is, will lithotripsy be an alternative or an adjunct to the established current procedures at the same time as the initial procedure for these severely calcified stenotic lesions? And I guess some of you alluded to it. I have a question in regards to when you're in the cath lab and you're going to do your intervention, okay, do you change or combine other calcium debulking procedures? Will you use laser and a cutting balloon, etc.? And if not, why would lithotripsy be an exception where we can use that as an adjunct to other current procedures? Because currently, it's only that I've seen in the studies that were international, not the U.S., that lithotripsy could be an adjunct to the current procedures.
So thank you for the question. And the answer is yes, both. And so I think that we'll see this used as a primary strategy in a lot of patients, and then we'll also see it as an adjunct or sort of bailout, and there may be different reasons why. So let's talk about just from a primary adjunct. In the DisruptCAD-3 study is that this was used as a primary modality in 384 of the 431 patients that were studied. And so this can be used as a initial strategy for debulking or softening up the calcium there with, in the study, very proven good success, low complication rates, and then with no additional debulking needed in the majority of the cases. This may be an advantage in several of the cases, particularly if we're talking about in-stent restenosis of a heavily calcified lesion, or perhaps even in bifurcation lesions, is that this may be a primary choice in lesion characteristics. Again, this may be used as an adjunct or a bailout in certain situations. Some of these were alluded to earlier. So if we went in with a high-pressure balloon, or if we did atherectomy and we failed to get the stent, the vessel expansion that we needed in order to deploy a stent, is that using this as an adjunct would be helpful. And then finally is that if we did place a stent in a calcified lesion and we were not able to expand it appropriately, is that we could then follow with the shockwave balloon or the IVL balloon in order to assure good stent expansion, which means a better outcome for the patient in the long term. So the short answer, again, to repeat that, would be I think we'll see it both. Primary strategy in many cases, but also as an adjunct strategy in those where we need it for failed other strategies. So thank you.
Thank you so much. Any follow-up from anyone else? I don't see hands up. So for the sake of time, I'm going to go on to my last question. And this question is for Dr. Tui, as well as, I guess, and Dr. Winchester. And you alluded to this multiple times, so for saving of time, just brief opinions if you can. Are there different considerations for treatment depending upon the location of the coronary artery calcification? That is, in which artery is affected? How did the IVL compare to CABG for left main calcification? And is there evidence to show that IVL is safe now for use in left main, considering it was not, that's not one of the inclusion criteria?
Yeah, thanks. Yeah, what do you want to do?
You go ahead.
Okay, so I mean, there are differences depending on the location of the coronary calcification between left main and the remainder. Each vessel has its own unique characteristics, and there's advantages over using IVL versus rotational atherectomy in the right coronary artery, for example, and not needing a pacemaker. The left main coronary artery has separate distinctions, whether it's a protected left main or an unprotected left main, having had previous coronary bypass grafting surgeries. I was unaware of, comparative data, or I couldn't glean out from the studies any comparative data of CABG versus left main disease per se, but a number of the studies went over left main disease use within the populations that they studied, and some compared it to the others, and some just included it. So I'll go over that very quickly. The Disrupt series actually had very few left main cases. Only Disrupt 3 had 6 left main cases, but it was safe and effective there. In the AXOI study, propensity scoring comparison of IVL versus non-compliant PTCA, they demonstrated there was an equivalent rate of MACE, whether you used intravascular lithotripsy or used non-compliant balloon angioplasty in those left main lesions, with a predominance of using NC balloons there. In Oliver's study, there were 59 patients who had left main with 1 year follow-up, and they were compared to 450 non-left main patients. And similar procedural success with similar TBR, death, and MACE at 1 year were exhibited. Gibbs' study also 1 year out, only 11 patients, which was 23% of the total study, but they demonstrated in that there was utility in high risk and ACS patients, and those patients, as they evolved over time, had low MACE rates despite being higher risk patients. That was redoubled in Wong's study, real world IVL use in South Korea versus rotational atherectomy. Again, small numbers, 16 absolute patients getting IVL, but they had less no reflow, less contrast use, less fluoroscopy use, and less incidence of perforations in the coronaries. The Gupta study showed safety and efficacy of IVL for nodular calcium, another area that we've touched on, but a unique advantage for Shockwave in that significant nodular calcium is present at the left main bifurcation going into the LAD, ramus, and or circumflex. And about a third of the patients in this study were left main bifurcation nodules, and there were 0 deaths at 30 days with about a just under 10% rate of cardiovascular death at 1 year in this high-risk population. The Von Oort study showed in 454 patients over 5 years, of which 57 were left mains, that there was a low complication rate, under 1%. The overall MACE at 1 year was 13%, and did not differ between the two groups. McInerney also looked at a small number of left main nodular calcium in significant numbers. Again, similar success and low MACE rates were seen as the Disrupt 3 trial. And finally, Rola's study had 131 consecutive uses of IVL, again with about 20% of the cases in this were left main, so a low MACE rate. But overall, I think there's substantial evidence that using this in left main disease is safe. And, we've added in these higher risk patients over time and been able to do patients who were surgical turndowns for coronary artery bypass grafting with protected PCI using Impella support and low EF. And we've actually been able to get away with cases, at least in our practice, of doing it in unprotected left mains with normal ventricular function and careful, judicious use of the pulses, and be able to do left main bifurcation angioplasty in those cases. David, add-on stuff, I hope I left some time.
No, I think you covered it completely. I don't have anything to add.
Thanks.
Thank you so much for that very thorough presentation with the list of all the studies to help us. Very much appreciated. I'm going to go on to my last question, which will be for Dr. Hafiz. And this is more so just to see if for long-term outcome data. Most of the studies that we have seen or read are really based upon you have data 1 year out, maybe for some out to 2 years, but the numbers are so small in the study. So is there long-term outcome data that you have seen in your practices where coronary lithotripsy is sufficient to support this procedure? And please opine on any of the long-term outcome data regarding the restenosis rates, the frequency that you might need a repeat cardiac intervention versus going to a CABG or MACE compared to the other current procedures that are calcium debulking procedures.
Thanks for the question. In my research of this topic, I found the coronary IVL was approved by the FDA in February 2021, and that's from the time where most of the commercial use started getting used. And this is based on the DISRUPT trials. The pivotal trial would DISRUPT C83, single-arm prospective multi-center trial, and had a primary safety endpoint of freedom from MACE at 30 days post-PCI with efficacy of treating less than 50% visual stenosis. And this is similar to what others have said, similar to the ORBIT-2 trial for orbital atherectomy. The DISRUPT C81 trial wasn't done in the 2015-2016 era, so we're looking at a very relatively recent technology in the grand scheme of things that we've done in the interventional cardiology world. IVL is still considered relatively new, although there's about a decade of experience now with it. Most long-term data published in the literature is in the 1 to 2 year range from my research of this topic, and there have been significant changes in how IVL is practiced now compared to the initial DISRUPT trials, such as use of rotational atherectomy, Lithotripsy, i.e. what we call it, use of IVL in in-stent restenosis, which was not studied in initial trials, sometimes a very low rate of intravascular imaging or IVL use as a bailout instead of the upfront use of the technology itself. This was done either after stent was delivered and the stent was found to be under-dilated, and this is what the real-world registries demonstrate. To me, the data is slightly difficult to replicate and compare with various studies versus the initial DISRUPT studies. So you cannot really make a one-to-one comparison. Also, the DISRUPT studies did not have a control arm. And this was based on what others have said, being based on other trials which preceded DISRUPT studies, and they were all prospective single-arm trials. With these caveats, data so far shows robust and durable safety and efficacy, the biggest advantage being its ease of use, as others have said, very similar to a basic percutaneous intervention techniques. You basically deliver a balloon over a wire and start doing your IVL and inflate the balloon target lesion, requiring no significant training compared with atherectomy devices such as rotational or orbital atherectomy or excimer laser, for which the supporting medical staff also needs to be trained, and not only that, they need to maintain their competence. And not all labs can do these kind of interventions compared to IVL, which is much simpler. There is a European registry which tracked 273 patients from 2018 to 2021, despite the above-mentioned caveats, and showed procedural success of 99% at a median 2-year follow-up, approximately cardiac death of 5%, and MACE, major adverse cardiac events, of 11%, with a target lesion restenosis of 6%. The shorter follow-up, there was a Polish registry of 131 patients in native or underexpanded stents treated with IVL, showed at 6 months the MACE rate was 7.9 and TLR was target lesion revascularization of 3.8%. I'm not aware of CABG explicitly being a target for outcomes post-IVL, as by definition it is mostly used for single lesion vessel problems, and that was the objective of the DISRUPT 1 to 4 trials. And it's unusual for CABG to be done for a single lesion failure, especially after given the lower incidence of left main IVL in these trials. for which CABG would be the upfront strategy. So CABG pre-exists in about 9% of the population. Disrupt-3 trials, multivessel CAD was not the target population they were studying, especially given the syntax score, which determines the overall burden of the coronary disease, and the score ranged from 15, 20, 22, and 23, which is in the low to intermediate range by definition, and favors non-multivessel PCI treatment rather than CABG. In acute coronary syndrome patients with IVL, IVL was used as bailout or Lithotripsy in a published registry of 15 patients. Average syntax score was just about 20, and MACE rate was 13 at 6 months. Follow-up with any revascularization for this particular population was 33%, with a target lesion failure of 6.7% in this high-risk population, which is different from what the Disrupt trials have studied. Despite these high-risk cases, the 6 months MACE rates are remarkably low overall and very comparable across different trials. Even when PCI with IVL is done in unprotected left main in a majority stable angina and STEMI population, schema-driven revascularization at 1 year unspecified by PCI or CABG, you could do both, was only 6.8%, while cumulative MACE was in the 10% range and death was only 4%. Studies comparing head-to-head different coronary decalcification modalities are rare, again, to my knowledge. Only comparisons are based on historical cohorts of the registry data. There is a study group from Netherlands that compared rotational atherectomy to IVL and reported 6 months follow-up in balloon crossable lesions that were heavily calcified. By definition, you cannot deliver IVL if it's not balloon crossable. It found no statistically significant difference in procedural success. 82% was 92% at 6 months, and the MACE was 12% versus 6%, and similar outcomes. Even though numerically IVL favored, but in the study sample of 101 patients, IVL had a significant lower fluoroscopy time, as was mentioned earlier by the speaker, which holds up to the ease of use case scenario that has been described and a shorter learning curve for IVL compared to other traditional atherectomy devices. The OCT subset of the Disrupt trials, they show that calcium modification is circumferential. It's unaffected by wire bias, unlike rotational or orbital atherectomy, although the IVL compared to all other CSC modification devices, including scoring balloons, affects deep wall calcium, which is very different from other modalities, and this avoids the barotrauma that happens. And also avoids heat generation. It is little surprise that the Disrupt trials consistently, all of them, showed very low incidence of target lesion, overflow, slow flow, perforation, or serious top dissections type D to F. I'm finishing my little monologue here. A different retrospective study mentioned about comparing IVL versus rotational atherectomy in left main population, again, found no difference in cumulative 1-year MACE, which was death MI revascularization, which is driven by ischemia. A group for Emory, mentioned by the speaker for Emory here, reported findings from a 50-patient retrospective study comparing IVL versus rotational atherectomy in left main calcific disease, and more than half of them had bifurcation lesions, reported significantly higher technical success without MACE in IVL versus rotational atherectomy, 98% versus 86%. This was statistically significant, with lower procedural complication with the IVL group. Another recent study comparing IVL and rotational atherectomy in CTOs from a multi-center registry showed no significant difference between the technical success, procedural success, MACE. However, there were more perforations in the rotational atherectomy, 9.5% versus 3.2%, and this was highly statistically significant. Besides lower procedure time, and so on and so forth. So a similar themes observed in other studies. There was a study from Singapore which showed similar findings. So in conclusion, number one, long-term data is limited to only 30 days, 60 months, 6 months, and 1-year data mostly, and shows favorable procedural success with MACE around 10%, with most reporting it lower than the Disrupt CAD protocol patients. MACE starts rising if you start using it as a bailout rather than as upfront or in acute coronary syndrome population, but it still stays less than 15%. Number two, repeat revascularization, regardless of how or why it is done with PCR CABG, is a rare phenomenon in the majority of IVL patients. And number three, rotational atherectomy and IVL provide similar outcomes in most retrospective studies, with trends toward better outcomes with IVL and balloon crossable lesions, but shorter procedure time, less complication, and one study actually superior with IVL, although no direct prospective randomized trials exist. Thank you.
Thank you so very much for that detailed presentation. And I see that Dr. Blankenship's hand is up for any additional comments.
Well, that was quite a tour de force, and so congratulations to Dr. Hafiz. I think one perspective that might be valuable to think about here is that, in a sense, when you're starting to dig a hole, it doesn't matter if you start with a pickaxe or a shovel. You want to get the hole to the right size, and kind of like this, no matter what you start with, you want to get that final stent that goes in fully expanded, and I think it doesn't matter too much which of these techniques you use, as long as you get that final end result of an excellent stent expansion. And I think what we're hearing is that the IVL does this as well as any of the other procedures, if not better, and probably more safely.
Thank you so much, Dr. Blankenship. And I think, Dr. Rob, your hand is up for a comment.
Yes. So, we can be Rob again. That's excellent, Dr. Hafiz, a very good overview. So the restenosis rates are lower, or at least comparable to the other devices. At least in our experience, when we talked about bifurcation regions, there are patients who are not going to be candidates for coronary bypass grafting for a variety of reasons. And things like balloon, putting this bifurcation side branch, or rotational atherectomy, or other devices does not give an optimum result at the ostium of the side branches, the left circumflex. The shockwave IVL seems to work well in that area in modifying the plaque at the bifurcation so that you have better stent expansion, and lower restenosis rates. So that's what we discovered and published in that article, that if you want to lower restenosis rates, putting at bifurcations, IVL may be a better therapy.
Thank you, gentlemen. Your expertise is very much appreciated here. And at this point, I'm going to turn over to my next colleague, which I believe is Dr. Lovelace.
Hi, this is Dr. Lovelace from CGS, and my first question, we've already touched on this, so I'm just going to see if Dr. Winchester has any additions, if any measures of the intravascular ultrasound, and should there be something like a point system for patient selection?
Thanks. Yeah, I was a little unclear on some of the elements of the question, so I'll start with what I had prepared as my comments. So I looked at this in a couple of different ways. The first way that I looked at it was comparing comparing PCI with and without IVL, and I think that one of the key elements here is because of the capacity for how IVL modifies plaque as compared to other options that are available to interventional operators. This particular technology has the potential advantage of making PCI in heavily calcified vessels safer than other strategies like rotational atherectomy or high-pressure balloon systems. And that's got to do with how the technology works as compared to what other systems are doing. I did note that there was one review article that specifically commented on IVL with and without the use of embolic filters and noted no difference in outcomes if those safety devices were or were not used. And then I took the broader picture to comment that, as new technologies like these come to market, I think it's obviously important that operators who are no longer in a training environment have expectations and opportunities to participate in, appropriate level of proctoring. We also have a fair amount of post-approval monitoring data, and it may or may not be worthwhile to continue some of those as these products become more frequently used in the clinical setting. That said, I would welcome any other comments from the other reviewers if they had any other thoughts about what specifically might be done to improve the general safety of this system.
I don't see any hands up, so I think that you covered, I think you must have covered it well. So we'll move to the next question. And for Dr. Blankenship, and this is and we've also discussed a lot of this in our discussion, but we're again comparing intravascular lithotripsy to other calcium modification techniques. And is there certain factors that you would consider when choosing the calcium modification? And I think what I'm going to take this a different direction just because we've already discussed this. So I think one of the challenges that we have here is that we've got the disrupt studies, which are, we have a prospective single-arm, multi-centered trials with 1 and 2 being fairly small sample sizes and 3 being large sample sizes and 4 being a small sample size in a non-U.S. population. And so we have with 30-day outcomes with the exception of the follow-up on CAD3. So, you know, typically these prospective single-arm studies are going to be considered low to moderate in terms of their quality, depending on sample size and bias risk. And then when we're comparing the intravascular lithotripsy to other procedures, the majority of our data is retrospective. And when we're in Medicare and we're by law required to make policy decisions based on evidence and meeting that reasonable and necessary criteria, it gets challenging when we are dealing with largely low quality evidence. So that's where I'm trying to tease out where the evidence supports this over another procedure and where the evidence is supporting the advantages that you're discussing of the ILP compared to some of the procedures which you've clearly defined as more risky.
Okay, well, thank you for that question. And I think I'm going to compare it to each one of several different modalities, but I think we've moved beyond that. I think one of the limitations is that these other modalities have patient selection factors. For instance, you can't do rotational atherectomy on every case. So you carefully select the cases that you're going to do rotational atherectomy on. So any trial with rotational atherectomy is going to be, say, limiting the types of lesions and the situations you can use it in. By contrast, I think intravascular lithotripsy can be used in pretty much a wide spectrum of different patient situations like stable disease, even STEMI or acute coronary syndromes, and a very wide selection of different kinds of lesions. Just as one example, for instance, you would avoid using rotational atherectomy on a severe bend. But with intravascular lithotripsy, if you can get the catheter around the bend, it should be as safe as anywhere else. So I think that when you look at some of these even retrospective studies and you see that you have, they succeed in delivering the stent 98 to 100% of the time, what that means is that once you decide to pull the lithotripsy catheter out of your toolbox and deploy it, you have a very high likelihood of success at a very low risk. And a lot of those cases are ones where you would not pull your rotational atherectomy catheter out. You would leave it in your toolbox and say, well, this is not, it's either too dangerous or it's not anatomically suitable for this particular modality. Does that get to your question?
Yes, and I appreciate your descriptions that a non-cardiologist can understand, so thank you. So then that leads me to, if you're able to do this on patients that you may not be able to utilize other calcium modification techniques, is there any long-term risk? Would that be taking a patient that might have proceeded with a surgical intervention or a more aggressive intervention into a stent, and does that have equal success long-term? Basically, I'm trying to understand, are we putting patients potentially at any increased risk that would have gone on to a more aggressive therapy that we're delaying because of this, or is it providing them an alternative to avoid that? And the biggest concern, I think, is that our data is so short term that I don't know if we know 3-5 years out what's going on.
Well, I guess one could argue that the technology is so relatively easy, safe, and effective that you might pull it out in a case of a person who perhaps would have been better served with bypass surgery, somebody with 3-vessel disease and diabetes with heavy calcification, and you would normally say, well, they're better served with bypass surgery, and that's probably true whether you tried it with stenting or intracoronary lithotripsy followed by stenting, but the lithotripsy might make it so easy that people would be tempted to do what ultimately is not in the patient's best interest. But I think that's about the only situation I can think of where that would be so. Sometimes we talk about when you do a full metal jacket with a stent, in other words, you stent from the top to the bottom of the artery, you're cutting off the option of doing bypass surgery later because the surgeon has no place to put a graft in because it's all been stented. You don't find that here. Again, it goes back to that idea that if your final goal is to get a well-deployed stent, it doesn't matter how you get it there. And any one of these technologies that is effective in getting the stent well expanded at the right spot, I think is equally effective and in most situations does not limit further interventions down the road.
That is so helpful. Thank you. I just want to see if there's any other comments on this before we move. Dr. Rob?
Very quickly, you mentioned the cost issue, and that's obviously a concern for all of us, for ECMS. But remember, just like when rotational atherectomy started, more than 25 years plus, the costs have come down. And, like this particular device has 4 competitors already out there. So the cost of the device will come down with time. And that's one of the concerns. But the device is really here to stay. Thank you.
I just want to clarify that we actually don't consider cost in the Medicare reasonable and necessary criteria. So we focus on patient outcomes and safety and does it improve long-term outcomes. And Dr. Hafiz?
Yes, this is Dr. Hafiz. So my comments are what we have known is coronary calcium is getting worse. And I think this is across different commenters who have mentioned this. We see more and more of it, more length of coronary calcium lesions. And we need adequate tools that are modern to deal with it. Atherectomy and orbital rotational are based on mechanical debulking, which is one of the older ways of treating this lesion. And this is a brand new technology with a completely different philosophy of how to treat. Not only does this address a different subset of calcium, which is deep calcium versus superficial, calcific nodules are better treated with this lesion. And also the most important cause of stent failure is underdeployment. So my comment is also that this technology can be used in a lot more hands than the atherectomy orbital or rotational. So you can use this in smaller labs, less experience, and with less staffing expertise.
Thank you. I just have one question as for a CMD to echo Dr. Lovis's concerns, is that part of our role, though, is looking at the clinical evidence to support doing this. The numbers are very low in many of these trials. The patient population numbers are very low, and the follow-up is shorter. And that is where I think we're struggling to say, you're saying it's great. You in practice, you've mentioned a lot about registries. Where can we get data like that to say, okay, we're looking at the clinical trials and the literature out there, but it's short term and it's small numbers. And is that safe enough just on this low level of evidence to support that this is a procedure we should be going with? You all do that in your practice out in the real world. Everything is evidence-based and looking at big trials. And, if you're faced with the fact that there's only, maximum 100 patients or 60 patients or 12 patients with left main, for us to write a policy, is it very safe for us to do that?
And I see Dr. Corpus.
Yeah, so I agree with everything that has been said. I think, Dr. Hafiz, I agree with you. So the calcification is getting worse. So we have an increasing population that's aging. We have, prevalence in diabetes, renal failure. So I think it's going to get worse. I think, at this point, we're looking at, as Dr. Blankesh said, we're not looking at IVL as an endpoint, as a tool to deploy a stent. The endpoint is an optimal stent deployment, which will confer, an optimal deployment to less restenosis and stent thrombosis. So that's the ultimate endpoint. And I think to go back and compare, the modalities is going to be probably not feasible as we have such a good safety endpoints. I think we'll have to rely on these registries. And I think registries are the way to go. And, I think, there's some come in Europe, that over 400, we're going to mention that Netherlands registry over 400 patients. A high percentage of those patients had ACS, and their outcomes were excellent. So I think going forward, there's evidence, cannot be randomized prospective studies, but I think the registries and the number of patients with safe treatments will be probably the, way to actually, look at the evidence.
This is Dr. Barry Bertolet. Just to add on to your question there, is that when I look back at the Orbit 2 study, which was orbital atherectomy, which followed the same regulatory pathway that IVL has followed that same regulatory pathway. In that study, there was 443 patients. And so again, when we look at Disrupt 3, that was 431 patients. And so when we're looking at the size of these studies for this type of disease that's out there, is that these studies and the populations numbers that are out there are appropriate to gain regulatory support.
Yes, and I do want to clarify that FDA approval and coverage are not the same. So we, in addition to the safety and the efficacy that the FDA pathway looks at, we also have to look at patient outcomes, the long term, and so that's where I'm just trying to tease out where the data aligns.
And just to echo that, and what I mean by that is you do now pay for atherectomy. And so it's the same thing here, is that the same number of patients were studied and you approved that technology. Now we have the same number of patients, and you're hearing from the people that use it is that we get similar results and probably more safe. So this is something that I think that by the numbers in the clinical trial, but also what you're hearing from us, should support its coverage.
Yes, I appreciate that and the expertise. And I think that what we're trying to understand is that unlike orbital atherectomy, where it seems to be applied to a fairly specific lesion, ILP is easier to has a shorter learning curve. So it's in the hands of a lot more cardiologists than some of these more advanced technologies like the orbital atherectomy, and being used off-label from the indications with a much higher volume than those. So we're just trying to understand and seeking your all's guidance and what is the evidence support and not support in terms of these off-label use and the rapid expansion of the technology. And we can, I see Dr. Rob after your comment, and then we can just keep that in mind as we continue to work our way through the questions.
Medicare supports ASCs, and the device safety. This device would probably be more used in ASCs because it's safer to get better outcomes for the patient.
Dr. Lovelace, you're on mute if you're talking.
Oh, okay. I apologize.
Mm-hmm.
We can continue with Dr. Rob for the next question. And this one is that regarding the comparators, and does having different comparators impact the outcomes?
So my response is going to be brief. It really does not impact the devices per se, because in all the studies that you have mentioned or quoted so far, the safety profile is comparable to both rotational orbital atherectomy. And it's probably safer because the number of perforations are much lower with this device. In some studies, almost zero compared to rotational orbital atherectomy. So that's the best answer I can give you. Look at all the studies that have been quoted so far.
Great. Thank you. And if there's no other comments on this one, we'll move to the next question, which is for Dr. Hafiz and Dr. Corpus. And the technology is FDA approved for severely calcified de novo coronary lesions prior to stenting. And this is going back to that off-label use. And I'm really interested in focusing on the evidence. Is there evidence? I guess really in the absence of evidence, these would be limitations. So is there evidence to say these should not be limitations?
So if you want to take the first three, I'll take the last three.
Sure. You want me to start, Dr. Corpus?
Sure.
Okay. So I'll start with the first point. Yes. So the answer is I have answered most of these in my responses to the first question that I did. For the record, second question I answered, the references have been emailed. There were 16 references to that question answer. So the combined with other calcium modification devices, yes. As you mentioned, Lithotripsy, which is a term where you combine rotational atherectomy with IVL, is a well-described technique, and this data supports its use. In addition, one retrospective study, propensity score matched the study, did compare IVL with high-pressure balloons and corneal calcified lesions, and reported significantly higher rate of procedural success with IVL versus the non-compliant balloons, with a pressure of greater than 16 atmospheres deployed. Mean pressure achieved was 29 atmospheres in the latter group. So procedure success was significantly higher with the IVL group versus NC group, and this was 82.5% versus 61.4%, and the p-value was less than 0.05. Although the 12-month MACE was similar in the two groups at 10.5% versus 11.5%, and overall complications were less than 1% in either group. About 20% of patients, though, had moderate coronary calcification study. Conclusion data for IVL versus other modalities exists, but is only retrospective registry-based, as has been pointed out, and no head-to-head high-quality propensity prospectively randomized data exists. Based on limited comparative data, IVL has unique advantages, as has already been discussed extensively, but hard outcomes data is largely similar across modalities. You can take the next one if you would like, Purpose.
So next one, a better procedure with stent in place. I think there's some data suggesting that late instant restenosis, even actually early under deployment, actually has significant benefits from IVL. There was a study that utilized 100 patients, and out of those were 55% of those patients, or 55 patients, were actually old stent placement procedures, such as instant restenosis. But 45 of those patients, 44%, were actually acute under-deployed stents. And IVL was utilized in both patient populations, and the success rate was actually very similar. So the question was, what is the mechanism here? And typically, with immediate under deployment, there is calcification outside the stent, and that those calcium deposits can be fractured by IVL. And the concern of the study was obviously, is there any damage to the polymer by these shock acoustic waves, and then did not translate into a significant restenosis. So the conclusion of an acute stent under deployment situation is that IVL is effective, can break up calcium outside the stent without the damage of the polymer. Of note that the stent layer did matter. So if it was actually 2 or 3 stent layers, the efficacy was actually a lot less. The late data, again, 55 patients out of 100 in that study were actually late instant restenosis patients where actually calcium was inside the vessel. the mechanism there is actually similar to de novo lesions, breaking up calcium deposits, in the scar tissue inside the stent, and that also actually was a quite favorable outcome with regards to the MACE procedures at 30 days and 1 year. So there's evidence that actually IVL can be used in stent restenosis as well as underdeployed stents in acute setting as well with safe outcomes.
I will take the next two briefly, and then I'll let you continue with the corpus. So we're talking about the off-label and limited limitations of technology. So this C part of the question is anatomical locations, bifurcation or left main. Yes, there are numerous studies supporting the use in left main, and one specifically reports outcome in bifurcations. We have discussed this earlier. Having said this, generally bifurcations in the non-left main lesions tend to have worse outcomes, and that necessarily is not a limitation of technology. It's just the nature of the disease, whether you use IVL or don't use IVL. Acute coronary syndrome, the DISRUPT-3 study excluded NSTEMI and STEMIs within 30 days if it had occurred, but subsequent registry and retrospective data, as mentioned earlier, and response to question number 10, included acute coronary syndrome patients across the spectrum on stable angina and STEMI or STEMI, with the latter being the smallest subset. Outcomes were not compared separately, to my knowledge, between ACS and non-ACS groups directly. In a 2021 meta-analysis by Alvarez et al., the ACS varied from 26 to 45% across the studies in their analysis and the reference provided. A similar number was reported by International European Multi-Center Registry at 44%, which found an increasing trend in ACS patients treated with IVL at the cost of decreased use of other CSU modalities, coronary calcium modalities. Most were NSTEMI, 25% patients, followed by unstable angina, 12%, and STEMI was the least common at 7%, while just over half were still chronic chest pain patients at 56%. IVL use rose from 33% in ACS to 48% from early to the later part of that registry. Both technical and procedural success, usually defined as technical success without any adverse MACE events, was high at 91% and 89% respectively, while MACE rates at 1 year were relatively low at 13% despite the inclusion of ACS patients, some of which were bailout IVL, which is known to have higher rates of MACE. And only 8% clinically driven revascularization events and 4% mortality within a year. Very briefly, in responses, lesion size and total occlusion, this has already been discussed in my earlier discussion. Back to you, Dr. Clippers.
I just brief comment on the eight-point syndrome, the registry that you mentioned that had 14% MACE rate. If you look at the other Texas registry or study at 9 months, the MACE rate was 24% with rotational atherectomy of the similar patient population. So again, looking at real world high prevalence of ACS, 13% versus 24%. Again, not a direct comparison, but similar patient population between IVL and rotablation. Lesion size, we mentioned that briefly. Obviously, catheter comes in different sizes, in 2.5 up to 4, which is currently treatable vessel sizes. If you look at lesion size, we did mention that the balloon length is about 12 millimeter, but with increasing pulses, we can actually treat lesions that are longer. In the DISRUPT studies, lesions have to be less than 40 millimeters, as we mentioned before. And again, I think the third three-dimensional aspect of lesion size is deep calcium. Deep calcium typically is defined with OCT or IVUS of calcium that's more than 0.5 millimeters inside in the vessel. Now, those lesions actually have deep calcium or effectively treated with IVL. It's been shown that both superficial and deep calcium are fractured about 70% of the cases on the intravascular imaging. So lesion sizes limitations are the vessel size, the length, and the calcification. Again, those are the treatment options for IVL. Total occlusion per se obviously is not feasible to treat with IVL. You have to cross the lesion with a wire. However, if you have a successful crossing, you can use hybrid techniques such as rotational atherectomy, and then IVL can be safely utilized. However, again, total occlusion by single use of IVL is not indicated.
Just a comment about the calcium depth, 5 millimeter, and then probably best seen with OCT, but OCT is not always employed. Thank you.
Thank you very much, everyone, for the excellent education with your answers. And I'm going to turn things over to Dr. Barr.
Yes, thank you. And I think that we're now in a couple of questions that we have touched on with a few of your really excellent answers. But this question is directed to Dr. Rob, and it is, does the use of calcium modification devices improve percutaneous coronary intervention outcomes? And the follow-on to that is, for what duration is outcome data available?
Thank you. So if you have a calcified plaque or any plaque, the goal here is to get the maximum benefit from stenting with the widest stent area and with very little indentation of the body of the stent. And the whole goal is that you prevent the scar tissue formation coming back, or the growth of the calcified nodule through the stent strut, so the patient does not keep on coming back with recurrent cardiac events or acute coronary syndrome. So the goal with any percutaneous intervention is an optimal result. And with whatever device you want to use to modify plaque is absolutely essential and important to get to the optimal goal for optimum stent expansion. So yes, calcium modification optimizes stent expansion and reduces MACE and in-stent restenosis. There's plenty of data out there. And if you have a suboptimal result, and if your stent is not well expanded, the lesion is going to keep on coming back and haunting you. Now, in terms of trials, most trials looked at outcome data at 30 days. And so if I looked at the IVL literature, most of the initial trial data was at 30 days. That was for orbital or rotational aspect. Thank you.
Thank you, Dr. Rob. Sorry, I had trouble getting myself off mute for a second there. So moving on to the other speakers, did anyone else have anything to add?
I just want to add a brief comment. IVL is a new innovation, and as we've seen on the structural cardiology side, TAVR, for example, and they keep innovating different new technologies, and the follow-up is going to need time, and probably the same will happen with IVL. Just a matter of time before the studies have long-term data. It's just that the technology hasn't existed for so long.
Thank you. If any other comments beforehand, we can move to the next item, question 16. So again, this touches very specifically on another question that was asked, question 9, but adds on a little bit in terms of the percentage failures. And this is directed towards Dr. Blankenship. The prompt here is, are there different considerations for treatment depending on the location of the calcification, i.e. which artery is affected? How does lithotripsy compare to bypass for left main calcification? The follow-on to that is whether there is evidence to show that lithotripsy is safe for use in left main disease. And so those are the elements that were specifically touched on, and the more specific question, if you'd like to add to it, is what are the percentage failures at 1, 5, and 10 years?
This is Jim Blankenship. Is the question about percentage failure specific to left main or in general?
Yeah, it is directed towards left main.
Okay. So I think the answer is yes, there are some different considerations for treatment depending on the which artery is affected. One example would be that rotational atherectomy, for instance, can cause what's called, again, no reflow, which if you use it in the left main can be catastrophic, and which always makes us pretty nervous when we use it in the left main, and in some cases, we would use Impella support to do it safely. In contrast, the IVL requires you to blow up the balloon in the left main for a short period of time, which in somebody with normal left ventricular function, at least, is generally reasonably well tolerated and produces a predictable result, as opposed to the catastrophe that you sometimes see with rotational atherectomy. So that's one example when one might, faced with a left main lesion, prefer to use lithotripsy as opposed to, again, my favorite alternative, which is rotational atherectomy. So that's one example of differential use of it. And I mentioned previously, there are some types of lesions in some arteries where the other modalities either can't cross a lesion or can't be safely employed. So there is evidence that it's safe. There are retrospective studies that looked at left main. I can supply references, but the evidence there basically is that the lithotripsy is at least as safe as the other calcium modification modalities. So main diseases, yes, it is safe. There's always a little more risk with left main disease because if anything goes wrong, of course, then it can be catastrophic, but that's true for any of these modalities. And again, I think the lithotripsy is more reliable. Percentage failures, we've talked about follow-up. We don't really have follow-up beyond 2 years. The follow-up at 2 years is generally pretty good. There's different ways of looking at failure. One is target lesion failure, which is specifically usually defined as thrombosis or restenosis within the treated lesion requiring revascularization or causing a complication such as myocardial infarction. And then there's overall major adverse cardiac event rates for the patient, which generally run for 1 year at about 5 and 10% respectively, and for 2 years generally run at about 8 and 15% respectively. And the data for lithotripsy and bypass, the data for lithotripsy generally falls into those ranges.
I see Dr. Bertollet has his hand up.
Yes, sir. So just wanted to add to that very nice answer. A couple of things is that when we look at left main stenting as compared to bypass surgery, directly just looking at that, there's been no difference in mortality and outcomes when you look at those different procedures. The big thing I think it's important to understand is that oftentimes this is not an either or, but it may be that if somebody has left main disease, that we oftentimes now use a heart team approach where we will consult with our surgical colleagues and we'll decide what's the best way to approach a certain patient. And using that heart team approach, a lot of times these patients are denied CABG, or they're denied the opportunity for that. And so if we did not have technologies like this that were available to us, then that would provide either no option for the patient or a very dangerous option for the patient, as outlined by Dr. Blankenship earlier. So I wanted to add some color commentary to what he added. Thank you.
Thank you both for those excellent responses. Are there any other comments from our subject matter experts? Okay. So I think we can move to the next item, which is, again, going to be directed towards Dr. Bertollet. This does touch on some of the limitations that were discussed earlier, but I think it's phrased differently enough to make it worth asking, which is what are the contraindications for intravascular lithotripsy?
So I think this will be a quick answer. So the contraindications are few. So the first contraindication would be you can't get the balloon there. And so if you can't cross it with the IVL balloon, then you can't do the procedure. So that would be a contraindication. So if it's you can't get a wire across, you can't get a balloon across, then you can't do the procedure. I believe that there is evidence of active thrombus. That would be likely for me an absolute contraindication, at least for now, utilization in bypass grafts, unstudied in that arena there. And so I think that would be an absolute contraindication. So for relative contraindications, as mentioned earlier, these balloons come in certain sizes. So I think that if we were to try to use this in a vessel that was beyond the size range, the size matrix that is presently available, that would be a relative contraindication. And perhaps if we were retrying a vessel where there was a previous perforation or a bad dissection, that may make it, I'd say, something to think about from a relative contraindication standpoint. But I would limit it to just those few. Thank you.
Thank you very much, Dr. Bertollet. Did any of the other subject matter experts want to opine on either relative or absolute contraindications in their opinions?
I just want to make a brief comment.
Yeah, this is Dr. Corpus. Just a brief mention about, this phenomenon of ventricle capture. We haven't talked about this, but this rate of shock waves is about 1 pulse per second, so it turns out to be a 60 beats per minute heart rate. It has been shown actually in some studies that there's some ventricle capture that's actually observed in patients. Mostly have the heart rates less than 60. Male patients, and it's correlated with the number of impulses. And again, speaking for the safety of this procedure, this did not translate into any high-grade arrhythmias. So I think, if you look at, someone with a low heart rate, you could anticipate capture of the ventricle. But again, it's safe. It did not actually increase any risk of arrhythmias, definitely not, ventricular fibrillation. Just to be mentioned that is unexpected. Not a complication, but a feature, and it's safe. Again, should not be a contraindication if someone's heart rate is lower than 60.
Thank you, Dr. Corpus. I saw Dr. Hafiz had a comment as well.
Just to comment about the ventricular capture, I just want to add that the only thing that was observed was transient hypertension, and that did not have any clinical relevant outcome. The other thing was a comment about the CTOs. There is actually a utilization, and there has been a couple of comments about coronary total occlusions. There was a registry which did specifically study that this device has been used in CTOs, probably best after the lesion is crossed, but it cannot be used up front as the lesion cannot be crossed.
Thank you, Dr. Hafiz. Do any other subject matter experts have a comment before we move to the next item? Okay. So with that, I will pass it over back over to Dr. Mullen.
Thank you. So, Dr. Hafiz, is it appropriate to perform these procedures in ambulatory surgery or office-based centers without surgical backup? And if so, who, if any, would or would not be eligible?
Thank you for the question. This will be a brief answer. Of all the modalities of coronary calcification, IVL is the simplest one to use from a technical aspect. It is a low-risk intervention with excellent safety profile, as has been discussed by other speakers, when performed per protocol that was used in Disrupt 1 to 4. If you follow the exact protocol, you're going to be a very safe place. With very low risk of perforation, slow flow, no reflow, and so on and so forth. And we discussed this in detail in my response earlier. Over time, modifications have been made to techniques that are used with IVL, as has been discussed earlier, which slightly elevate the risk of MACE, but reduce the procedure time. In some cases, compared to rotational atherectomy, actually reduce complications in the short term. The SKY document, which is an expert consensus document on PCI without on-site surgical backup, the references provided, and it suggests the IVL can actually be used in ambulatory setting with no on-site surgical backup. However, typically these sites will not have other modalities such as rotational atherectomy and orbital atherectomy devices to be used as adjuncts if needed. While the document suggests that other scenarios to avoid in ASCs such as low EF, CTOs, calcified lesions, unprotected left vein, degenerative vein grafts, or high bleeding risk patients, there is little data to guide as to which specific coronary calcified lesions are best suited for IVL in ASCs. In general, IVL should be available in ASCs, especially for bailout scenarios. However, best practice would generally dictate that severe calcium, the broad spectrum of severe calcium that we see on a day-to-day basis is best treated on a surgical on-site backup facility with full spectrum devices capable and technical staff who can handle those strategies and where there's logistical support. Having said that, I think it's very appropriate to leave it, and it is covered for ASC use.
Thank you. Dr. Rob.
So at the present time, at a lot of level 2 STEMI centers, which do not have surgical backup, the safety of the device in most communities, IVL has been used there without surgical backup. So there's quite a bit of data now from all over the country that this is a standard practice, particularly when people are concerned about rotational orbital atherectomy. And you do need atherectomy in a lot of level 2 centers in the country now routinely. I think in the greater Atlanta metro area, most of the level 2 hospitals have IVL without surgical backup.
Thanks, Dr. Rob. Dr. Corpus, next question for you. Please opine on the additional training and certification requirements for physicians and medical staff.
Sure. My opinion that the training requirement is minimal, and my opinion is supported by evidence. Mostly in the Disrupt 3 study, when looked at the safety and efficacy of this procedure, it was similar rates of success and safety in 47 centers that had a first case compared to the subsequent 384 cases that were done. So pretty much, the operator experience is given by the standard techniques of delivering the balloon. So specifically, no additional training is required for physicians. I did confirm with the company that also for staff, they typically have an in-service one time when they come to the cath lab. They teach them device hookup, the balloon prepping, and typically they support the next couple of cases. But typically, it's a one-time in-service for the staff. There's some CME, CUs that can be done as well, but typically the requirement for training is minimal.
Thank you. And just to clarify, you said you reached out to the company to confirm the in-service. Is that correct? I just wanted to make sure I understood.
Yeah, correct.
Okay, thank you. Dr. Tui, what ICD-10 diagnosis codes do you think are appropriate for this technology?
Yeah, so I think in this case, it's very similar to the standard PCI code, so it would include the I-20 series for angina, as well as I-21 and I-25 series for both acute myocardial infarction and atherosclerotic heart disease, as well as the I-11 and I-50 series involving hypertensive heart disease as a potential cause of anginal chest pain, as well as the I-50 heart failure series for patients who have compromised ventricular function related to their underlying coronary artery disease. But basically similar to those. I poured through some of the other diagnosis codes and did not see anything that was compelling. I don't know if my colleagues have anything that they would add specifically to that list.
If you look at I did a search on Google and AI and all that sort of stuff. There are also a series of codes like 02F03ZZ, 02F13ZZ, 02F23ZZ, and 02F33ZZ. I think that those come from the atherectomy literature, I think, more than anything else.
Yeah, I think those are not like current codes that we'd be using routinely. I don't know if you have any insight into that, Dr. Blankenship, my RUC guru.
No, I can't answer that.
Yeah, like I code, right? The ICD codes don't have usually ZZZ in it, right? That's kind of subtext for some of what we do in the RUC for the global periods and the. I don't know. But I think that's an adequate list.
Yeah.
Well, Blankenship is the expert here, so he's a guru in this. So.
Yeah, he's the mentor.
Oh. Well, thank you guys so much. That was our final question. Before we close, are there any closing comments? I know we are over by 10 minutes, and I do apologize. So I do want to open the floor if there are any comments that you guys would like to make just for a few minutes.
I think it's amazing it's only 10 minutes over. I congratulate my colleagues on their brevity assessment and learning curve during the course of questions.
Yeah, I learned a lot, and I congratulate staff on keeping it on track. Good going.
Yeah, I think it was a good team effort by everyone.
Thank you. Dr. Havis, one second.
When you put a group of cardiologists in the same room, just remember from CAP conferences and all that, everyone will come up with a different stenosis of that lesion and a different answer. So to have a group of experts like you in the room able to answer 20 questions that were complex, okay, is totally amazing, and totally love what you all did for us.
Yes, thank you, Dr. Natasky. Dr. Havis, you were going to say something as well.
Yeah, I just want to end the session by saying thank you, everybody. And it goes back to what I mentioned, Dr. Mullen, and of course I heard about this conference is IVL. It is a game changer for us who have been introduced to technology, have known how difficult and cumbersome the other technologies have been. So with that in mind, I don't have any other questions, and thanks everybody. This has been a really incredibly learning experience.
Yeah, same for me as well. As well as please feel free to send any additional literature, written comments, written answers, supplemental answers to my email or the NGS CAC email within the next 2 weeks. We're grateful for the substantial effort you devoted to reviewing the evidence and for your very thoughtful contributions today.
And just second our appreciation for your time and expertise. I know I learned a lot. I'm sure everyone did. And this concludes our meeting.
Thank you very much for asking us to participate.
Thank you.
Thanks to everyone.
Thank you.
Thank you.
Thank you.
Have a great evening.